G'day, my name is Michael. I'm a paramedic from Canberra in Australia, and tonight we're going to be talking about primary and secondary surveys. So normally the right way to start these off is with a bit of a patient story or why you should care or some other sort of background about, what you're going to learn. But given I'm currently just a little floating head in the bottom corner of your screen, I thought I might start off with who I am. My name is Michael. I'm a paramedic and a paramedic clinical educator from Canberra, Australia. I'm passionate about educating, and that's kind of the big bulk of my job these days. And I also work for both the unis, teaching some different years worth of, paramedic education there. And I work for a private company as well, teaching pre-hospital response and pre-hospital medical care to both first responders of various types and also kind of lay people responders. I'm really passionate about bringing kind of the evidence base of what we do and the best practice and translating that into real world application, because my personal view is that you don't need to translate that. If the evidence is there and it supports what we should be doing, then it's what we should be doing and we don't really need to adapt it. On that note, I'm also a researcher, and I spend a fair bit of my time thinking about kind of how people respond to stuff like this. I was approached a little while ago about presenting this for you guys, and I was super keen. Like all good people, it's about 10 o'clock at night, and between 2 day shifts, and I'm recording this. So if I seem a bit tired or I get a bit confused, I'll put it down to that. So without further ado, let's get started. All right, now let's start with the why. So why do we all learn a primary and secondary survey? And then we'll talk about what and kind of discuss what we're actually trying to do with these primary and secondary surveys. And then finally, we'll kind of go with how, and we'll talk about a model that's been specifically designed for pre-hospital care, because a lot of the models that exist at the moment are either designed for the layperson responder, which is fine and they're super usable for that, or they're designed for an in-hospital setting. All right, the why. Why do we need a structured approach? All right, because this saves lives. So this guy here, this is Dr. John Hines. He passed away a little while ago. He was a doctor and an anaesthetist and a traumatologist and all sorts of other really cool things. And he really was a big proponent of this idea of taking the best care to the patient, particularly the critically unwell and the critically injured patients, because death won't wait for you to bring the patient to a hospital. The other reason that we really need structure, though, is because we all know that we operate in kind of a land of chaos, and particularly when things have gone wrong, whether that be a car accident or a big medical event or a building collapse or a fire or anything like that, that chaos is everything that's around us. And if I get really obnoxious and high-level academic with it, there's actually a theory that talks about what makes paramedics specifically different compared to our other healthcare professional colleagues, and it's by Campbell, and they really talk about the fact that there's this idea of space control, and that what sets paramedics apart can be the fact that they are allegedly able to come in and control the scene around them and bring chaos out of order. Correction, bring order out of chaos. I don't know, I definitely feel like sometimes I bring chaos out of order, but order out of chaos. All right, so apart from the fact that this slide is broken and already given you a little bit of a cheat sheet, let's talk about how the perfect job should run. So the overarching approach. So we arrive to whatever we're going to do, and we're going to do our primary survey. And the idea with your primary survey is that it should be the identification of life-threatening injuries. So these are the things that are going to cause a really big problem for your patient that you need to do something about fixing them kind of right now. Otherwise, they will die. And that is the ultimate goal of your primary survey. One thing you'll notice throughout this talk is that I don't differentiate between a trauma primary survey and a medical primary survey. My personal view is that that's actually a differentiation that we don't need to make if we pick a model and think about our primary and our secondary in the right way. and hopefully that becomes a little bit clear by the end, because don't really differentiate between the two. Right, so we've done our primary survey, regardless of whether it's a traumatic injury or a medical complaint, and then we're going to do our resuscitation. That is fixing those things that we've initially found in our primary survey being wrong. We then, as the head to toe that was already there kind of implies, do our secondary survey, and that's a nice, thorough, methodical head to toe assessment, making sure that we get all of the required assessments done, so that we make sure we find all of the potential injuries or find all of the signs and symptoms related to whatever clinical presentation we think we're seeing. We're then going to do any specific interventions that come up from that secondary survey. And then there's a concept called the tertiary survey, which is about the documentation of injuries and illness after we've done those investigations. That can also take the form of a handover. And then we pass that patient on to whatever further care they're going to. So that right there would kind of be the perfect job. Show up, primary survey, bang it out. It's great. Do whatever resuscitation stuff you need to do. You've probably saved their life in that point. Give yourself a little pat on the back. Do your really thorough head to toe. Make sure you get your stethoscope out, listen to them, because obviously you're going to do that wherever they are, and make sure that everyone sees that you look really cool while you're doing it. Pat them down, look at your hands for blood. There isn't any. You get to your specific interventions. You do whatever you need to do, whether maybe that's give them something for pain, or position them, or give them a little bit of oxygen. And then you do your tertiary survey. So you're going to do a handover. You're probably going to look really cool while you talk on the radio, and then you're going to write it down in really neat handwriting so everyone can tell what you've done, and you'll hand them over to further care, whether that's the helicopter that shows up, or you take them to hospital yourself and everyone says, congratulations, you've done an amazing job. And we all know that kind of isn't really how it happens when it hits the road. So what is the goal then of our primary and our secondary surveys? So kind of like we said at the top, our primary survey's job is to rapidly assess and treat life threats. So if we're going to say we're going to assess and treat life threats, we probably should be targeting that towards whatever the things that are most likely going to kill you are. And statistically, particularly in trauma, there's 4 things that consistently kill you. And they are, of course, an airway obstruction, respiratory failure, hemorrhagic shock, and a brain injury. And for particularly any of the Australians or New Zealanders that are in the room, but other parts of the world as well, will probably recognise this as the ABCs. So A for airway obstruction, B for breathing or respiratory failure, C for circulation, so hemorrhagic shock, and D for disability, so brain injury. Now, there are lots and lots of acronyms out there. So there's Doctors ABC, March. These are all great and tailored towards specific use cases. But what I'd ask you is Doctors ABCD enough of an approach? So I'm going to talk about this one specifically because it's probably the algorithm that I'm most aware of. And like I said, I know that there's others out there, such as March, or there's an ABCDEFGHIJK as well, because that's how many letters they get up to apparently. So Doctors ABCD would be danger, response, send for help. Some then there put a catastrophic hemorrhage, and then ABCDE on some of them. But is Doctors ABCD enough? Well, I'd argue that probably for our setting, it may well not be, because, I mean, there's no mention of C-spine there. How do you apply it in an MCI? Dangers? Well, of course there are dangers. That's kind of half the reason that you're there, is because something dangerous has happened. So just saying, oh yeah, there are dangers, doesn't really point us in the right direction. Right, here we are. Here's some science and some evidence. This is a paper by Kolbeck et al. I looked at a synthesis of the primary and secondary surveys in paramedicine. And this is what's called a Delphi study. And a Delphi study, in a snapshot, takes all of the experts from whatever the given field was. In this case, it was paramedicine, actually teaching paramedicine. Then gives them a bunch of questions about different stuff, all related to one topic. So for example, in this, it would be, in what order would you rank the importance of these different bits of a primary survey? and then it brings them together and synthesizes them. And the researchers can then use that to gain kind of this idea of like expert consensus, when you hear that term, about probably what's the best thing to be doing. And this works really well when there isn't a lot of evidence, or alternatively, there is huge amounts of evidence to support practice going in either direction. Right. So how they do it? Well, they looked at a bunch of different places. It is heavily weighted towards Australia and New Zealand. They do acknowledge that. Basically, every jurisdictional ambulance service in Australia and New Zealand was involved, along with South Africa, UAE, and Qatar both had separate ones in. UK had a couple, and then the US had a few different national registry level guidelines involved as well. They found that if you look globally, there are more than 100 unique assessments and interventions identified in these guidelines, and that's a lot of assessments and interventions to get done in just a primary and a secondary survey. So let's talk about how we're actually going to do this. So if we've decided that it's so important to make sure we have a really structured and methodical primary and secondary survey, so we move towards whatever our goal of care is in a nice systematic approach, and we can help bring some of that order into the chaos. We've decided that we probably, should do it with some level of speed. How are we going to actually go about doing that? Well, the acronym that I'm going to suggest to you guys today is FIRST GET ABCDE. So it does piggyback off the back of the ABCD or ABCDE that most people will be aware of, but it does it in a way that's specifically developed for pre-hospital practice. Right, first get. Now I really like this bit because it really breaks down that kind of the D or the DR into a very specific and kind of pragmatic approach. So safety, so taking our universal standard precautions, PRN as required, so whether that's gloves, eye protection, helmet, safety, whatever you'd normally need to be doing to get to that scene. F is for fear. Does anything make you fear that the scene may be unsafe? I'm sure we've all had that feeling where you kind of get a little bit of a pit in the bottom of your stomach. And that's often that our subconscious is really, really good at picking up on things that are this kind of the subtle danger, like it implies at the end of the paragraph there. I, incident. Determine the nature of the incident while entering or on the way. And that's part of where we can start doing some pre-planning on the way to the job. We'll know potentially what it is or what we're likely to see, and we can start thinking about stuff like what patients are we expecting to see, what injuries, and by doing some of that pre-planning on the way, it means that we can essentially hit the ground running. R is for number. Determine the number of patients involved while entering. So that's doing that really quick count. And I'm not thinking in this point that I'm going to go, 1, 2, 3, 4, 5. It'll be like one, a couple, or heaps. Like I'm really just doing a very, very quick, like, am I in an MCI or can I do with this right now by myself? And that's all I need to do there. S is send for help, because I always like having help and bringing friends along. So making sure that we're calling for backup or notifying whoever else is coming or asking someone else to come nice and early. Trauma or triage. So consider trauma to the patient's C-spine kind of as required. So that's also related to that I for incident. Are we expecting that there might be C-spine injury there? For example, a high-speed motor vehicle collision or a fall from a great height, or go into triage. G is your general impression. So develop an impression of the situation. That's really building, as opposed to our clinical awareness of what's happening, our situational awareness around us. Develop an impression of the overall situation, and that might be where you do your report to dispatch, is what they suggest. And eyeballing stuff like approximate age, gender, where they were, and apparently just on first observation, how concerned are you about them? Are they in a lot of pain? Are they really distressed, or do they not look that well? Or do you kind of see them and you think, oh, that's really not good. E is for estimating the level of awareness. So we can either go down the full GCS at this point, which some people suggest, or we can go to AVPU. So AVPU is a shorter acronym that some people will be aware of, which is either alert. V is for verbal, so responds to verbal. So you call out or say something and they kind of open their eyes or react really in any way. P is to pain, so a little trap squeeze, squeeze on the finger, or U is unresponsive. So if you give them a nice strong squeeze and they don't respond in any way, then they would score an unresponsive. If they do only respond to pain, they suggest including a motor score, but personally, I would just call it responds to pain and move on from that point. Determine if they're oriented to person, place, and time. So if they are awake, are they actually super, super confused, or do you genuinely believe that they are awake and with you? Assess for any immediates to self, team, patient, bystander, etc. Before beginning the ABCDEs, and consider POPE for your threats. So people, object, places, and environment, and control of catastrophic or life-threatening hemorrhage as required. And so that's first get. So that essentially takes care of the DR or the DRS or the DRSC that's in doctors ABCD. But like I said, I think it breaks down particularly some of the safety stuff, because it talks about both safety for the patient, safety for us, and safety for our team in a really kind of pragmatic way. And then, yeah, ABCs, here we go. Use a find it, fix it, move forward approach. And what that means is that we are going to assess, because you can't fix what you can't find. So we're going to assess, and then we're going to fix it if it needs to fix it, and then we're going to move on to the next thing. If we can't fix it, then we haven't been able, if we haven't been able to fix it, then we can't move on to the next thing. So assess, is the airway patient? Does it need clearing? Are there current impending or impending obstructive difficulties? So look, listen, feel. Is the airway patent? Looking in that airway, physically seeing, is there anything in there? Having a listen, can you hear air coming in and out? Does it need clearing? Consider positioning, so rolling them on their side, sitting them up, suctioning. If there's foreign body airway obstruction, whether that's back blows, chest thrusts, whatever happens to be in scope for you. Basic airway junks would come in at this point, airway adjuncts rather. So that would be OPAs and NPAs. And depending on your system or your scope of practice, that might include some supraglottic airway devices like iGels particularly. Advanced airway adjuncts can be considered, but that's a pretty early point to be considering. You'll hear lots of people will talk about some of the advanced airway stuff will be in a secondary survey, but there definitely are patients who require that advanced airway or a surgical airway in their primary survey, like it is an immediate life threat. B is for breathing. Look, listen, and feel, and assess the respiratory effort. Consider a rapid 4-point auscultation if appropriate. So if you can hear their chest clearly through whatever clothing or over the background noise, then a 4-point auscultation, so listening to the tops of each lung and the bottoms of each lung, can give you a heap of information about, are the lungs up? Are you actually getting oxygen and air in and out? Consider whether you are going to put on your SpO2 at this point and end-tidal carbon dioxide as well if you have it. So this would also be the point where if we assess that we need to start breathing for them, we'll start using a BBM. If we need to apply oxygen and chest decompression or whatever for a pneumothorax. C is for circulation. So again, is there a pulse or not? Looking at a carotid, feeling for femorals will be the most reliable, because we know that as your blood pressure drops through either bleed or shock, that you start to lose your pulses from the peripheries inwards. So we'll start preferably with a radial, so on the wrist, and one on the neck, so the carotid, because that will give me a little bit of information about if I can feel one but not the other, or I can feel both, or hopefully not feel neither. Rate, strength, and regularity. Perfusion estimation is only insofar as adequate versus inadequate. So eyeball them. Do they look bad? Do they look good? Are they shut down peripherally, so they're very dusky and blue on the hands? Or do they, have good perfusion distally? Assess for any uncontrolled hemorrhaging, and a quick look at skin condition, which I measured before. So direct pressure and tourniquets for uncontrolled hemorrhage. Remember that at this point we are not so much talking about that life-threatening catastrophic major hemorrhage, but we're talking about big bleeds. CPR if vital signs are absent, potentially an IV at this point, and then maybe an ECG if you're doing ECGs. All right, and then we talk about, well, our ABCs again, but we're talking about our D and E, so disability and extrication. So this, although I said don't differentiate between D and E, this one does differentiate between D and E. Medical uses Bangzac push, so benzos for seizures, adrenaline for life-threatening bronchospasms, so like your asthmas, your anaphylaxis, any of those breathing or respiratory-related conditions. Our opioid overdoses, so narcotic overdoses, who are apneic or not breathing well, they would get N, naloxone, glucose for hypoglycemia, ZAP, defibrillation or cardioversion, or push fluids for hypovolemia. That Bangzac push acronym, some people really fall into a camp of liking it, and other people find that the use of the kind of the primary and the secondary guides them in pretty much the right direction without needing specifically to consider bang, zap, and push. And then trauma, we're looking for essentially badly broken or bleeding. Broken bones causing complications, particularly your head, spine, ribs, pelvis, or femurs, so anything kind of in the trunk and the head. Internal bleeding or a pneumothorax, and just eyeballing. Are they not sick, sick, very sick, dead? The badly broken or bleeding is a really good way of approaching these. I know that when I first started learning, I had to memorize DCAP, BTLS, TIC, and assess that for every single body part. Deformation, contusion, abrasions, punctures and protrusions, burns, tenderness, lacerations, swelling. And then tick was the bit that I could never ever remember. But the badly broken or bleeding is probably, at least for a brain like mine, much easier to approach and actually assess on our patients. And then E for extrication, and I personally also use environment in here, or environment and exposure. So expose the patient, making sure I'm actually being able to see what environment are they in, and they talk about that at the top. So current environmental conditions, heat, cold, wind, rain, are they in the sun? Is it going to start raining on them? Egress route to transportation. So how are you actually going to get them from wherever they are now, whether that's trapped in something or stuck in something or just upstairs or downstairs, to whatever you need to extricate them, whatever vehicle you want to take them away in. And then finally, kind of considering things like whether this is an emergency or an immediate or a rapid extrication, whether we're going to be needing additional assistance. So they're a bariatric patient, a very large patient, whether they're a pediatric patient who might need a different type of restraint, whether you have the need for an air ambulance or a helicopter, and then finally, like appropriate destination, it talks about as well. So are you going in the right to the right hospital, but also consider this as, do you have the right type of backup coming? Then your sides face, so that's good as well. So regardless of what acronym you use for your primary survey, there are really just three kind of primary rules of our primary survey. The first one is that it should take kind of less than 10 seconds to complete your initial primary survey or a primary survey, assuming that nothing is wrong with the patient. Obviously, if something's wrong, then you need to spend more time fixing it. But if you just need to work your way systematically through a primary survey, it should only be taking us, about 10 seconds. Secondly, if you find a problem, you stay on it until it is fixed. That means that if the A for airway needs fixing, we don't go to B for breathing until A for airway is fixed. And that is kind of the real key to basically any primary survey problem that people have. And then finally, if there's a change, start again at the top. And it's up to you based on the scene you're in and the situation you're in about whether that's starting again, right at the top at that F in first gets, or whether it's in A, for airway. Remember that your change is not just something has got worse clinically. Your change can also be you've extricated. They're now on the bed. It starts raining. Something has worked well. Any change at all, really, we should be constantly reassessing these A, B, C, D, E's. And the more unwell, the more critically injured or the more acutely unwell your patient is, the more often you should be running through your primary survey, particularly your ABCs. All right, well, with that primary survey out of the way, let's move right along to our secondary survey now. So, what did they say about this? They said determining a mandatory set of physical examinations to be performed beyond vital signs was considered to be overly prescriptive and likely too complex. And I'm really glad that they said this because before I'd kind of come across or re-come across this article, I was trying to work out how to talk about this. And I was like, I really don't know how to kind of share a way of going about a secondary survey without coming off as overly prescriptive about this is the way you should do it, and then getting confused while I try and give every single one of those an if then. So they came up with this mnemonic for it. I see I had vitals assessed and treated. So I see I had vitals assessed and treated. And one of the things that's really good about this one is it also follows a format that similar to IMIST or IMIST AMBO, if you're familiar with those, works well for documentation, but also for handing over. Right, so the first I is identification. This is the thing that we all love to do, and that's not ask patients for their names. So I is identify the patient. Hopefully things like name, age, date of birth, address, kind of enough identifications that the hospital can work out who they are later. C, so the letter C or C, chief complaint or condition. What seems to be wrong? How can I help you? It's asking for open questions because we want patients to tell us in their words what is wrong. And because that really should be dictating kind of where their care goes and how we're going to give it to them. Once you've got those open questions, you can go for your focus questions. So what seems to be wrong? Oh, my leg really hurts. Oh, that's no good. Can you tell me more about why it hurts? Oh, it hurts because I hurt it. Oh, did you hurt it with the circular saw that's hanging out the side of it? Narrow your way in slowly rather than just starting off straight away with the why did you cut yourself with a circular saw? Prioritize the appointment of chest pain, shortness of breath, and altered mental status. What that means is that if you're someone who, and this doesn't really talk about it particularly, it kind of does, but if you're someone who approaches a systems-based approach with your assessments, then any of those, so your chest pain, shortness of breath, or altered mental status should be outweigh kind of basically all the other systems. Making sure we're asking, is there anything else? Making sure that we're not just getting stuck on those distracting injuries, but also not guiding with our history taking accidentally down into patients telling you heaps about one thing because that's what you've asked the questions about, and then they're not telling you about anything else because they just figure it's not important because you'd ask about it if it was. Incident history, they use a NOPQRST, which is kind of similar to OPQRST or Socrates as well, if you're learned that for a pain score. So when did the patient last feel normal, and then when did this onset? So this is kind of makes most sense for pain, but they are suggesting, which I think you can kind of use it for any type of history taking. Which actions are now provocative or palliative, so what makes it better or worse? What is the quality of the pain or the sensation? Is there any radiation or discomfort? What is the severity, 0 to 10 or mild, moderate, severe, or a visual pain scale if you have access to a visual pain scale? It's super important that we're not picking numbers for patients. Whatever their pain score is what they say that it is. A particular thing is patients will be like, well, my pain is a 10. That's fine, their pain is a 10. That's okay. What I like to say to patients as well is that it actually doesn't matter which number you pick. I still believe that your pain is there and I still believe that it's really, really bad for you. The reason I want you to pick a number is because I need to know in 20 minutes time whether you were at a 6 now and I've made it worse because it's an 8 or it's a 4. It really doesn't matter beyond that. It's just giving us something to work out where on that scale of pain you are and if things are getting better or worse. T is this typical, or was there any trauma leading up to it? And U is for undigested food. When did the patient last eat or drink, or what did they eat or drink? History, so that you might use sample for this. So signs, symptom, allergies, medications, etc. This breaks it down kind of into a different set of questions. Allergies, I like this because it talks about environmental, chemical, and food. Remember that people can be allergic to both medications and things that aren't medications, and both are kind of equally important. Drugs, so patient meds, the bane of everyone because they say a bunch of words, you can't remember what they were. Half of them are brand names and half of them are generics. But remembering to check, do they take any alternative or complementary remedies? Over-the-counter medications, particularly asking like, is there anything you take regularly over the counter or just from a shelf or from a pharmacist? Prescription, being sure to inquire about compliance. Now, compliance here is asking, do they follow their script accurately or are they a bit fast and loose with it? Do they take any illicit drugs? In how you phrase that is really important for how you get for the answer that you get out of it. And then finally asking, is there anything else? Being sure to exhaust all aspects of the patient's drug usage. Right, vitals. So level of responsiveness using either the Glasgow Coma Scale, so GCS, or an AVPU. Level of pain, skin condition, color, temperature, diaphoresis, turgor. So with skin turgor being kind of how elastic it is. Pupil shape, size, equality, response to light and accommodation. So pearl pupils are equal and reactive to light. Get a torch out of some type and shine it into their eyes. End tidal carbon dioxide, if you can monitor that, is pretty much essential. If you have the ability to monitor it, you should be monitoring it. Obviously, if you don't have the ability, then it's pretty hard to monitor it. Temperature, peripheral is kind of the best in most situations. Core is ideal, but it's rare that we can take a core body temperature pre-hospitally. Respiratory rate, depth, effort, and pattern. Actually count your patient rate of their rest rate. There's one vital sign that is most closely correlated to ICU admission and mortality, and it is respiratory rate. So we really need to be counting our respiratory rates properly. ECG, if you are doing ECGs, blood pressures, pulse rates, rhythms and strength, noting of any absent pulses. That means that we should be doing both radials. Blood sugar levels, if appropriate, oxygen or hemoglobin saturation, so SpO2, SaO2, but SpO2, whatever you call them. Assess physical. So in general, trauma, a comprehensive head-to-toe examination. And that's where the DCAP BTLS that I mentioned before, or a nice, good inspection and palpation and flexion and mobilization of all areas and joints is appropriate in a nice head-to-toe. In isolated trauma, so for example, a hand stuck in a machine or a foot run over by a car, just a focused examination of the injury is appropriate. You do a really quick full body head to toe, but once you're happy that nothing's there, for a foot injury, you don't have to spend hours looking in the ears for CSF because there isn't any there. In medical cases, a focused systems-based examination on the presenting complaint or condition, and that's what I spoke about before. That would be doing a cardiac assessment or a respiratory assessment, or a pardon me, a GI assessment. It's kind of beyond the scope of what I have time to talk about tonight, and it's kind of hard to teach just via, I was going to say Zoom, but whatever this is. But if you in doubt your critically unwell patients, I will always fall back on a head to toe anyway. And treatment. What treatment was performed prior to your arrival? Has someone already done all the hard work and glory work for you, rolling them on their side into the recovery position to open an airway? Have they already been doing CPR? The development of a treatment plan. So what do you actually want to get done for this patient in the next little while? And results of your interventions with ongoing assessments of the patient. And that's kind of getting into that tertiary survey that we spoke about before, and recommendations for further referral assessments or treatments that might be part of a comprehensive pathway. So what hospital do you want to take them to? What service do you want to get them seen by? And kind of almost touching on, well, why? So thank you for doing the good things that you do. Keep doing good things. Thank you for caring and thank you for spending some time with me. I hope that this was vaguely of some use. I found it kind of awkward. I've never really done presenting in this way. I much prefer having a group of people in front of me, or at least other faces on the screen to talk to. My contact details are around here somewhere. I'd love to hear from you via email or however else you can get in contact if you have any questions or want to talk in more detail about any of this. If you can't get your hands on a copy of the study that I mentioned, that International Paramedics Primary and Secondary Survey, then send me an email and I'll send you a copy or send you a link to where you can get the copy at least. In the meantime, thank you very much, and maybe I'll talk to you again sometime. But if not, like I said, thank you. Cheers.